Good evening, folks. We have many more joining us this evening, but welcome. We have a Tuesday webinar, Tuesday special, and we're so grateful to Dr. Keith Nagle from UVM to present for us. And we're really grateful for our friends at SK Life Science for their support of Epilepsy Foundation New England for so many of our events and webinars like this. Um, we're hoping we'll have some time at the end of our presentation for any questions, but if questions come up during the presentation, let's utilize the chat function and try to stay on mute just to avoid any interruptions. But with that, I think we'll turn it over to Dr. Nagle, and thanks again for being here.
Well, David, it's very nice to be here. Thank you all for joining. I got to say, I don't know if I'm blushing or looking nervous, but I'm feeling a little of that inside. I didn't realize what a large group would be on. I'm guessing at least some of you are Bruins fans. Hopefully you have that on in the background. We'll try have about 21 slides we'll talk about. And then we'll talk as long as it seems reasonable to address any questions or thoughts you're all having. I'll just leap in. Give me a second to just figure out how to share my screen. Guess I'll just say that I've been up at the University of Vermont since I finished my training at Columbia Pres in New York City back in 1996, and me and my two daughters moved up here, and we're really excited to start an epilepsy program. It's been a lot of fun. I've learned a lot with my patients and have really enjoyed raising my daughters up here. I'm going to share with you some thoughts in general about approaches to treating seizures, and then kind of narrow in a bit and go a little deeper on one of the latest anti-seizure medicines. Okay, and so share screen, hit the button, and I think we're good. And now that I don't have to look at small little details, I can take my glasses off. Okay, so we're in the 21st century, pretty exciting. And let's see, yeah, there we go. And so when talking about treating persons who have seizures, recurrent seizures, there's not a long list of different modalities. I have a lot of patients who I would say are therapeutic minimalists, right? We'd prefer not to take any medicine. And if we can, we'd like to take something really gentle. And but there aren't a lot of anti-seizure medicine ways to treat epilepsy. And so a patient is often left to decide, oh gosh, do I tread water? Do I stick with what I have? At least I hear words like, that's the devil I know, and you get kind of comfortable with something. Do I go to one of the, some 2.5 dozen other anti-seizure drugs that may be appropriate for my condition or my loved one's condition? There's anti-seizure medicines plus augmentative therapy. Things, normally we talk about like the ketogenic diet or the modified Atkins diet, not as a sole way to treat epilepsy, except for relatively rare circumstances, but as an augmentative therapy to allow you to take fewer or lower doses or to boost how well it works. And things like neurostimulation, likewise, seldom does it cure epilepsy, but it often makes it easier in some way or another. And then finally, there's surgical approaches, which often, if you've tried 2 good anti-seizure drugs for your seizure problem and you don't seem to be making progress, it might be time to find out, well, is it possible? What would be involved? And then, is it right for you? A number of my patients are very inhibited by the idea of having that, when in at least a subset of the cases, that may be the right thing for them. So looking at more of a long-term look at anti-seizure drug development or anti-seizure medicine development, you can go way back to, the 19th century when they were using bromides as really the first anti-seizure drug I think most of us would recognize. And then a big advance in 1912 when phenobarbital came out and was very helpful, though, a sedative medicine, and so a bit as a primary way that it works. And then in the 30s, Dilantin coming out, or phenytoin, a big break in that its main way of working wasn't to necessarily sedate. Of course, it can sedate, but that isn't expected. And then a host of medicines, through the 70s, and then a handful through the 70s to 80s. And then there was a sort of government sponsored anti-seizure medicine uh, development strategy to augment the development of medicines. And lo and behold, we have a number of anti-seizure medicines, a dizzying number of medicines shown up here on the top right of different medicines that have become available. And it's not that one of these medicines has risen to the top as a drug that's great for everybody, that is clearly head and shoulders above the others. It's more a question of having more options available. They all work about the same efficacy, although one person may respond to one drug and not another. And they also tend to be a lot easier to use in terms of drug side effects, the ease of taking them, different medication side effect profiles. So the hope is if one isn't tolerated or not working, don't stick with it. You might consider trying something, with your doctor to maybe get a better outcome. Of course, on the other side are worries about, well, I see a lot of fatigue in my patients if they try too many medicines too fast. And so there's that balance going on. I can see play out in my office quite often. Now, looking, how do these drugs come about? And in this graph, I'm not going to belabor this too much, but just to show that before this medicine gets to human beings, it's tested out in a number of animal models to see if it works and what the safety looks like. And then it will go into the first clinical studies. They're called phase 1 studies that help make sure that the medicine's safe and investigates if it's safe. And if it runs all through this gamut of tests, often over a decade, more or less, then it may be able to move forward into persons with epilepsy in controlled studies, and then finally seeking FDA approval and being available to you. So in terms of medicines in the last 15 years, I mentioned, by the mid 90s, there was a 15-year drought in new anti-seizure drugs, and then we got a handful of them, and then a few more. But in the last 15 years, we've had, a subset of medicines that have come forward. And although we'll concentrate a bit on cenobamate today, these other medicines have come on, and I'll say a quick word about them just to try to put them in perspective. Ezogabine, many of you will know, has been pulled from the market, which is, there's if you go to the Ben and Jerry's plant here in Vermont, they have a ice cream flavor graveyard, right, where you go in and they have flavors that just are out of commission. And there's a pretty big anti-seizure med graveyard of medications that were brought forward and for one reason or another were pulled. And so ezogabine was the first medicine that had a novel mechanism of action where it would affect potassium channels, which are really pivotal on whether a brain cell will fire or not fire and how excitable it is. And unfortunately, that was pulled, so we don't have that type of medicine right now. Perampanel is a medicine that affects a particular type of GABA current, and it can be helpful with focal epilepsy and some other types. Eslicarbazepine as a further modification of the carbamazepine, oxcarbazepine line with some favorable half-life features and side effect features. Rivitiracetam as a similar mechanism to levetiracetam, but again, I think one of the nice things about, say, being in America is you have a number of choices and you can kind of find something closer to the right key for your particular need or problem, in this case, anti-seizure medicines. Cenobamate, the medicine we'll talk about in a minute, and then fenfluramine, which is a newer medicine. It was originally part of the fen-phen medicine that will make many folks scared because that was pulled from the market for weight loss some time ago. I don't know if that was the 70s. But the combination of those two drugs together could cause some very concerning side effects. Fenfluramine is a bit of a niche medicine, like some of our other anti-seizure medicines. It's very good for a certain subtype of persons with epilepsy, particularly Lennox-Gastaut or Dravet-like syndromes. So that's a smaller subset. So without further ado, I think we'll start digging into the cenobamate. I do have one other sort of thought here. I see, as one is thinking, gosh, should I try a new medicine? I kind of feel like they're playing a game of blackjack. I don't know if many of you are card players. I'm not a big card player, but they kind of are like, do I try another one, or will I have a bad side effect or a bad experience? Will it ruin an upcoming vacation or a summer? And so there's that balance of, do I stay with what I have, or do I try for a better win, right? And you have to weigh where you're at in terms of your seizures, your side effects, drug interactions, whether pregnancy's in your future, and your fear level, right? So cenobamate, one of the reasons I think it's interesting to talk about tonight, in addition to it being somewhat newer, is it's had some excellent results in animal seizure models, and then as we'll see in a little bit more detail, it did really well with clinical trials in persons with fairly bad seizures. I don't want to get too deep into the physiology, but like many anti-seizure drugs, it seems to affect sodium channels. It has a couple ways it seems to do that, and there's several different classes of sodium channels, and different ones may have different mechanisms. This also seems to modulate a major inhibitory neurotransmitter called GABA. And it's not certain whether these two mechanisms that have been discovered are key to the efficacy of this medicine, or whether there's some other thing that we humans just don't understand yet. One of the first things I thought when cenobamate came out, I was like, oh no, not another felbamate, because felbamate was one of the first drugs that became available in the 90s, and we were very excited about it. But it did have some very concerning potential for side effects that we've learned to navigate a bit, but has very much limited its role. And if you're much of a chemist, most, I presume nearly all of us aren't, these molecules, the carbamates are the structure of a lot of different medicines. So it just happens to share that similar suffix to the back half of the name of felbamate, but is a different molecule in a number of ways. And again, although I have some, I had a decision to make whether to kind of dumb down the slides or to make it more easy to understand, or to keep the lingo, but just translate as we go. And as you see, I've chosen the latter method. And so the first two things here, area under the curve and C max, it's important because it some medicines are handled in an erratic fashion, and those pretty much say that when you double the dose, you'll get a doubling of the serum level and presumably effect, and it stays nice and consistent. So that helps the dosing. It's absorbed pretty well. It's not if drugs that are closer to 90% protein bound can affect how other drugs interact with this medicine. So this isn't an issue here. It has a fairly long half-life, and I would say this is an important differentiator of different anti-seizure drugs, right? There's so many different ways to think about them. One is, well, how long does it stay around, right? If you think about ibuprofen, right, that's some medicine most of us have had experience with. It usually has a half-life of about 6, 8 hours. So when you take it, it'll help your fever or some pain for about 6 or 8 hours. Some of our anti-seizure drugs, particularly in the old days, had to be taken 3 or 4 times a day because of short half-lives. And this one has a half-life that's long, a lot like zanisamide or even in the old days, phenobarbital. So it may take up to 2 weeks to kind of reach a cruising altitude in terms of getting, once you start a dose of a medicine, to kind of get to a serum level that's steady to assess how it's doing. So you can't take it for 3 days and think you've had an experience yet because it's just not long enough. And like a number of medicines, it's metabolized through a pathway through the liver. And one of the concerning things that will really keep you and your doctor on their toes are there are the potential for drug-drug interactions. And I would say that would be a more concerning trend. One of the nicer trends of a lot of the newer anti-seizure drugs is they don't have as many interactions, so they've been easier. We'll touch on more on that in a sec. I just want to consult my watch here. So this is really just taken from the Xcopri website as I was kind of first putting some slides together for residents and students. And this is an outline of their first 2 clinical trials. So I kind of talked about the animal studies and then the phase 1 studies to look at safety. And then they brought it to persons who had a lot of seizures, right? On average, about 9 seizures per month, which is a lot of seizures in my book. Hopefully not, and also in yours, I hope. These were folks who had seizures for a while and had been on a lot of drugs and were on at least 2 drugs at the time they came to this trial. So these weren't folks with the first seizure. These were folks who had been around, tried some medicines, were frustrated with very frequent seizures. Pretty tough group to show some efficacy in. And although I must say, with pretty much all of the drugs that go through the clinical pipeline, this is the kind of way they arrive to begin to be considered by the FDA and the medical community and you. So in this first study, 107 centers, 16 countries, they had about 400 patients at different doses, and they tried to look at safety and whether their seizure rate went down during the month. And this kind of outlines it. So they took folks with different doses, and this is time. So they got their first dose of medicine, and they walked the dose up, and then they looked for 3 months to see what happened. And what they saw was a pretty good dose-related effect where at just 100 milligrams, they had a 35% reduction, and about 40% of people had a 50% reduction in their seizures. And as you got up, and those who could tolerate 400 milligrams a day, there was a fairly striking thing that happened, which was a number of folks had a reduction in their medicines, both at 200 and 400. And we'll look at seizure-free rates in a moment. Now, there were adverse effects like there are in side effects with medicines, and they were dosage related. So, up to 1 in 5 at this high dose just didn't like how they felt on the medicine. And there was a case of severe rash in one person in one study, and another in a second study. As I'll show you in a minute, they did a third study with nearly 1,000 patients, and they did not have a address a case in that group. This is the slide I was meaning to tell you about, which is this is an interesting thing is that most of the time drugs are looked at whether they reduce seizures by 50%, a so-called responder rate. With this medicine, they had 90% and 100% responder rates that were in the 5 to 20% range in those that could tolerate it. And that's pretty exciting for us as having seen anti-seizure drug data come over my desk over the years. They did basically a duplicate study here in another group and saw similar things. This is basically over time, folks who had a reduction in seizure frequency versus those on placebo. And this is a very big difference. There is as you can see, if you give someone a so-called dummy pill or placebo pill, a sugar pill, let's say, some folks have some kind of symptom. And so Xcopri had a similar number, and they often talk about those who discontinue because of side effects. And those numbers got to be more significant at 400, but were, I think, within a normal experience with more typical doses. The most common side effects, I think, are well known to anyone who have taken an anti-seizure medicine, almost as a class: trouble with balance, dizziness, sleepiness, double vision, jerky feelings in your vision, or a sense of spinning. Are a possibility on these medicines, often dose related. And to see that also, there's a lot of people who won't have that, but it's certainly a side effect group that you need to keep your eyes open for. There were also some folks who had a slight elevation in their liver function tests, and in a electrolyte in their blood, potassium. And one also wants to check an EKG before and as you increase the dose of this medicine to make sure there's not a significant EKG abnormality that comes up. So in that way, it's not the easiest of the anti-seizure medicines to use, but with a trade-off of a real potential payoff in seizure control if you tolerate it well. They often start very slowly at 12.5 milligrams a day. Usually it's at about 100 milligrams that you'll start to see efficacy. And then if you haven't had response, then you dial up to 200 or as high as 400 if you tolerate it okay. And so the typical method is, go low and go slow, titrate it up, have a good communication stream, doctor and patient. And if there's concerns, back off or stop it until that concern is addressed. There's also a risk of these CYP2B6 and 3A and this 2C19 sounds like quite a bit of word and number scrabble, but these are different pathways that the liver uses to break down things, and including medicines. So we have to be worried about oral contraceptive pills with this medicine and be aware of this potential interaction, as well as carbamazepine, lamotrigine, and a couple other medicines. It's a little bit trickier, and you need to be very careful to monitor other medicines. So this was the study I was talking about, where because of 2 cases of this extreme rash, they then went ahead and did about 1,000 some odd patients. And if they found that if you go slow, they didn't observe that rash problem. So where does it fit in persons in general with focal seizures? So seizures that start in a particular place in the neural network as opposed to a generalized seizure. It's now FDA approved, and now, very importantly, there's over 100,000 patients who have used this medicine, and that's important in terms of uncovering rare side effects. I think this is a drug that's really had a good clinical experience, and um, um, I feel like the types of side effects we're going to see have been largely discovered and documented by now. And therefore, I don't think it's an ultra new medicine in that way because we have such a large experience already. Um, so those are my thoughts about cenobamate in a very frank way. Um, the future of anti-seizure medicine therapy, I think, is bright. I don't. I think the further advances, certainly there'll be continued medicines that line up on my initial graph from the 19th century to now, where we'll have new options, some which move into the anti-seizure drug graveyard, so to speak, and we don't use them anymore because they just aren't as good as some of the medicines that we hope are coming. The other important developments I think we'll see, and we are seeing a bit already, is using precision medicine to try to find those who maybe a medicine is not a good fit for or a better fit for, or maybe to discover a new drug target that may be better than those that we have currently. And then the other is identifying biomarkers, little traits, either genes or proteins or blood tests that might help us understand who's at risk for developing epilepsy and maybe finding ways to stop the epilepsy process. Those are the prepared comments I have today, and I hope that see if I can figure out how to stop sharing. I hope we can have a bit of a discussion, organized chaos of things to talk about. I'm all ears to any thoughts people are having.
Yeah, Dr. Nagel, thank you so much. We did have a question around the difference between cenobamate and lacosamide. I think that's the brand is Vimpat, is that right?
Yeah, there's so many different ways, tomato, sometimes like glucosamide and cenobamate. So, in some ways, there are some similarities. Glucosamide, one of its main mechanism of action an effect on a slow sodium channel. When cells fire, in a very simple way, when neurons fire, brain cells fire, the electrical impulse that comes down is a sodium, what's called a fast sodium channel. So sodium rushes into the cell and causes that cell to then fire. And so by tamping down that, allowing normal firing to go through, but tamping down abnormal firing is kind of the big goal here. And so cenobamate works a bit like that mechanism, plus two other potential mechanisms. It's important to keep in mind a couple things when comparing, modes of action of an anti-seizure drug, at least I think. One is there's several flavors of anti-seizure drug, of sodium channels. I can't keep up. I think the last time I looked, there were like 12 different classes of sodium channels, and where they are in the brain or in a particular pathway that might be causing seizures makes differences between other seizure medicines. So dilantin is a lot different than carbamazepine, is a lot different than lamotrigine. Those are all kind of traditional sodium channel blockers, what we call frequency dependent sodium channel blockers. Lacosamide, cenobamate work by a slightly different one, and in the case of cenobamate, possibly two other mechanisms, and also a little bit on this other GABA, this inhibitory mechanism. The other thing I would say that one needs to consider is that although scientists find these mechanisms, determining exactly how a drug works is pretty tricky. So it's hard to say if those are the key mechanisms of a particular drug or if there's some other mechanism. Our limits of knowledge grow, but we're not perfect yet. Thanks for the question.
Yeah, thank you. And another one, you you'd spoken to half-lives for various anti-seizure medications. Can you speak a little to maybe the comparison between cenobamate and let's see, I'm going to butcher the pronunciations here, but levetiracetam,
Yeah,
lamotrigine.
you can see why a lot of epilepsy specialists are kind of geeky about pharmacology of medicines because the medicines are so complicated and so many different ways to look at them. So levetiracetam, at least that's how I pronounce it. Again, the tomato thing. Uh, um, it is typically thought to have what's called a pharmacological half-life. How long, if you measure it in the blood over time, which is how they do this, they give someone a medicine dose and then they take samples of their blood over like every 2 hours over a 24 or more hour period, and they check the levels and kind of plot out, okay, the level goes up and then it goes down. And so that's about 12 hours, and that's why often it's dosed twice a day. It's curious. I do have some patients who seem to get away with taking it once a day. And there is a thought that it's pharmacodynamic half-life. That is, well, okay, once it's in, how long does it work for? And traditional medicines work largely by the classic model. There's a couple medicines where you get it in and it will last a while. Whether levetiracetam is one of those drugs, I don't know. So that's 12 hours versus this cenobamate, which is closer to 60 hours, right? So that's like taking it every 2.5 days, which of course you wouldn't do. One is you take such a high dose, you'd probably have a side effect. I'm sorry to use my hands a lot, but in this Heinz 57, as we say in Pittsburgh, there's a little Italian guy in there as well in my background, my American background of, if you think about, you take a medicine and your levels cruising around, pick a level, 10 units, and then you take it about a half hour to 90 minutes later, typically it starts going up. And then your liver or kidneys start digesting it down, and you get down and you take another dose. That's kind of the mechanism of how it works. The main point I was making is with our busy lives and sometimes memory, and it's sometimes hard to take a medicine 2, 3, 4 times a day. When you have a long set of when you have a long half life, that medicine will stay in there to be a bit smoother. I have found that, say, with a lot of my zonisamide patients, if they had a level of 17 2 years ago, and they're on the same dose, their level's 17, plus or minus a couple of units. There are some medicines where the levels go up plus or minus 20. So it's very easy to get focused on one thing, particularly if there's like a couple digits after, if it's 20.25. There are so many different ways to think about these medicines. Certainly, half-life's an important one when it comes to understanding the dose, how often you have to take it, how long it's going to be there once you take it. I hope that helped a little. It's hard for me to tell. I haven't done a lot of Zoom presentations this way. I usually can read the room pretty well. I can read names.
Yep. Yeah.
I'm not sure what I'm looking at. So give me some kind of feedback. Let me know if I'm getting to the thing you wanted to know.
Yeah. Let's see. You'd spoken a little bit to, some of the side effects and that we're seeing from cenobamate. You mind just touched on that maybe briefly again?
Could you repeat that? I'm sorry. I just
Just
had
some of the side effects that, some patients
yeah,
are seeing.
yeah. So, um, one, like a lot of anti-seizure drugs, you can kind of think of them as ones that just happen as sort of an allergy, right? So those are, we sometimes call in medicine, we call them idiosyncratic side effects. So a rash, whether it's a mild rash or a terrifying rash with fever and involvement of your mouth and your eyes and your scalp, right? There's that, which those latter things would be ER visit and very concerning. And then there's sort of dosage related side effects as you walk the dose up. So this medicine, particularly if dosed fast, has a chance of causing an idiosyncratic reaction, a bad rash. Sometimes a rash plus a systemic, immune problem. This medicine also has very prominent dosage-related side effects. So, or I should say, the possibility. So when you start at low doses, I think the chances are pretty low that it's going to be a problem. As you get up above 100 milligram to 100 milligrams, and then if you don't get response and you try to go up closer to 400, your chance got up closer to 20%, so about 1 in 5. And so that also means 4 and 5 did great. 1 in 5 had trouble with it, and those problems had to do with a lot of the kind of side effects you can see, like if carbamazepine, that is Tegretol or Dilantin, or Motrigine, or some of these medicines get too high. That's why I said it's a common song I hear, a cluster of symptoms. Sometimes I jokingly say it's like having a hangover with none of the fun, right? Your vision's kind of blurry, your balance is kind of off, you feel nauseous, you're tired, you're not thinking as clearly. And that's one of the reasons that I think they emphasized that you want to go slow as you titrate this up. Although the first time you'll see response is more likely 100 milligrams a day, if your brain reads the textbook, right? I'm sure someone will respond to 75 for all I know, but where was I going with that? So when you start walking it up, you should sort of keep an eye on that. And if you're like, well, I'm not sure, I'm on 50 a day, I've been on it for 2 weeks, I'm just not sure if this is a side effect. If you increase the dose, you'll probably know within 5 days to 2 weeks, because you'll have a higher serum level, and if it was related to the medicine, it should make it pretty clear. I think the trick with any medicines really is to do this in a controlled way, and at the first sign of side effects, hopefully you raised it just enough to cause a mild nuisance and not some major trouble, right? That's what we're all looking to avoid. And if we've had that happen once, we're more than twice shy, right? So I think a lot of my patients have a bit of a jaded, eye, or a little jaundiced eye on that. Once, if you've had a side effect to a medicine, it can make you pretty scared.
Are we familiar with insomnia being a common side effect here? Like it might be in some of the other anti-seizure medications.
I didn't come across that as a common one. And it was the opposite that was a little bit more of a concern, I think, so-called somnolence, or just not feeling as alert, fatigued, tired. One of the tricky things about that is I'm also a sleep doc, right? So I spend a day a week sort of helping sleep patients, and insomnia is real common. I mean, we've all had insomnia. Just about all of us have had insomnia, and so it's hard to know whenever someone has a symptom that's what we would call non-specific. These are things that happen in ordinary life. Is it that it's the medicine, or is it kind of you have insomnia, or it's declaring itself? And that's sometimes tricky to work out. But in general, if you start to develop a symptom, it's best and it's within 2 weeks, 3 months, a year of starting a new medicine, it's best to make sure it's not a side effect of the medicine. I usually tell my patients, look, if your teeth itch, if your fingernails are growing too fast, I don't care. If it's something different for you, I should probably hear from you. Just send me a little note, let me know what you're thinking, give me a sense of how big of a concern it is for you, and then we can kind of work out what we should do about it. And I'm always trying to balance working with my patients. You have this potential great tool, and if you have a side effect to it, well, we're throwing the tool out of the car onto the street or driving away from it. And there's a limited number of great tools. It's like having, I guess another analogy here, you can see I like to use analogies a lot. It's like playing baseball, right? If you have a team, you're going to try to pick your best pitcher. Sometimes your starting pitcher doesn't work out so well. So you go to your second string. Okay, if that doesn't work, you're going to your third string. If you're to your third string, that's a tricky place to be, right? Because at that point, if you've tried two medicines, I think it's time to see some, like an epilepsy center, a group of clinicians working together who emphasize the treatment of epilepsy in their practice to make sure that you're on the right road, that your diagnosis is correct, and to open up the menu of, well, what are the treatment options for you?